few years ago, when I was on the ACT team at Easter Seals, I treated a 30-year-old patient. He had schizophrenia and alcohol dependence. And so we did our best to treat his psychosis and alcohol use with medications. But something that fell to the back burner was his nicotine use. And we really didn't explore that further because we were so busy worrying about his hallucinations and his alcoholism. It eventually struck one of the team members to ask him again and explore further about his nicotine use. And we found out that he was smoking a pack a day for the last 10 years. When probed further, he said, "I want to quit, but I don't know how." So we started asking ourselves, as a team, what is the best way to treat this? What is the best way to treat his tobacco use disorder? So let's talk about the smoking rates. Amongst the general population, nationally, it's about 19% of folks who smoke. Now, within the behavioral health population, that actually ranges from 32% to 98%, depending upon their diagnosis. And an important fact is that about half of the cigarettes consumed in the US are by people with mental health disorder and or substance use disorder. And this obviously results in significant illness, death, and health disparity for two very vulnerable populations. As you can see from this graph, about 500,000 people in the US die from tobacco-related disorders. And of that 500,000, about 200,000 of them have behavioral health conditions. As you look at this graph, out of that 200,000, you can see that really is the total of the folks who die from obesity, drug use, suicide, and motor vehicle accidents. Now, far below that 500,000 per year number related to smoking is the deaths related to alcohol use, which is about 64,000 a year. And last year, about 50,000 people died from opiates. Now, the smoking-related deaths are, as you can tell, related to a combination of factors: cardiovascular, cancer, respiratory. This table shows you that basically, in folks with mental illness, they by far smoke more cigarettes than folks without mental illness. And when we looked at the trend from 2000 to 2008, unfortunately, the prevalence of smoking is really not decreasing in folks with poor mental health. And the red bar is of folks with poor mental health versus the blue bar who are folks with good mental health. And as you can see, the folks with poor mental health generally smoke a lot more than the folks with good mental health. Another really concerning issue is the lowered life expectancy. So the life expectancy of people with schizophrenia is about 14 and a half years lower than the general population. And this is felt to be largely attributable to the higher rates of tobacco use. And so this is a really important issue in the mental health field. And we have several studies understanding the relationship between smoking and mental health disorders. From the 2011 meta-analysis, we know that the effect of quitting smoking on mood is equal to or larger than those of antidepressant treatment for mood and anxiety disorders. We also know that continuing or starting to smoke increases the risk of returning to substance use after treatment. Additionally, smoking cessation interventions provided during addictions treatment were associated with a 25% increased likelihood of long-term abstinence from alcohol and illicit drugs. So what I'm asking for here, and what I start thinking about, is that we need a call to action for our healthcare system. In 2015, nationally, about 70% of smokers saw a physician, and only about half of cigarette smokers were advised to quit. And fewer than 1/3 of smokers who tried to quit received evidence-based cessation treatments. So I started thinking to myself, how do we address this issue on our ACT teams? How do we better address smoking cessation? So I thought, let's create an intervention. So I had a pre-intervention survey, an intervention, which was a one-day-long training, and a post-intervention survey. The pre-intervention survey was completed by 24 respondents on the ACT teams. Now, the questions there were a lot of questions about tobacco treatment behaviors, including prescribing, counseling, referring. And also, it gave me an understanding of the culture of their facility, the tobacco treatment culture of their facility. And also gave me an understanding of the current knowledge base about nicotine use disorder treatment. Now, the intervention was basically bringing teams of at least 3 people from each of our 9 ACT teams, which totaled to approximately 30 participants, including MDs, PAs, nurse practitioners, therapists, nurses. And they all came to Burlington back in May for a one-day-long training at tobacco dependence treatment. Now, that training covered treatment options, including pharmacotherapy, counseling, referrals, and resources available. Then I had a post-intervention survey with the help of North Carolina Medical Society and Aubrey's help back there, who helped me create a post-intervention survey and the pre-intervention survey. But I did the post-intervention survey. Unfortunately, I only had 13 respondents to the survey. But these folks that attended the training were resurveyed to see if there were any changes amongst their biases, the diagnosis, the pharmacotherapy, the psychotherapy, and referrals. Now, so I have the numbers from the pre-intervention to the post-intervention. Unfortunately, they're on separate slides, so I'm going to do my best to kind of summarize the changes that happened between the pre-intervention survey and the post-intervention survey. So from the pre-intervention to post-intervention, I noticed there was a slight improvement in patients being asked about tobacco use status, patients being advised to stop smoking and using tobacco, and patients being told about the benefits of quitting and the harms of continuing to use tobacco. Also, in comparing pre- and post-intervention surveys, there was an increase in the distribution of educational materials, and also an increase in providing follow-up for patients making a quit attempt. Now, across the board, from multiple disciplines, there was generally an increased feeling of responsibility to advise patients to quit. So as this graph shows, and just you'll have to take my word for it, but look at the graph as well. There is an improvement in the numbers of responsibility from pre to post intervention, from the nurses to the physicians to physician assistants and social workers. And also, there is a general increased responsibility to provide counseling and resources amongst all the different specialty disciplines that attended the training. This table basically shows what were felt to be the barriers and resistance to treating tobacco use amongst our mental health population on the ACT teams. And basically what I found was there was generally a decreased resistance and felt a decreased barriers by having the training from pre versus post intervention. There was decreased concern about time constraints, decreased concern about tobacco treatment not being seen as a priority, and generally people didn't feel like they weren't being supported from upper management after having the training in May. So an important fact about tobacco use is that it is a substance use disorder. and we know what works to treat it. Research indicates that the most effective tobacco treatment is a combination of evidence-based coaching and FDA-approved medications. In North Carolina, the tobacco treatment standard of care basically includes FDA-approved pharmacotherapy and evidence-based counseling. For the pharmacotherapy piece, either 12 weeks of Renaclean or 12 weeks of combination therapy, which basically means nicotine patches and nicotine gum or oral lozenge. And the evidence-based counseling, the most effective is the face-to-face individual counseling, but also group counseling and Quitline NC, which includes telephonic, texting, and web-based counseling, can be helpful. Please keep in mind that 100% tobacco-free environments can also help people quit. And when patients have co-occurring behavioral health disorder, they may require longer and more intensive treatment. The 5 A's of tobacco use treatment have been very helpful in me as I'm treating patients, especially after attending the training myself back in May. I learned to ask about tobacco use, advise tobacco users to quit, assess readiness to make a quit attempt, assist with a quit attempt, and arrange follow-up care. This is a little bit about the Quitline NC and what it is. It's an evidence-based telephone tobacco treatment service, consists of 4 treatment sessions, and there's a web treatment program and text service, and it's available 24/7. And the Quitline does have data showing that their counseling from the Quitline plus combination of nicotine replacement therapy is far more effective than physician advice alone, or just counseling alone. Just a few updates since we had that training in May. I have helped set up all of our ACT locations as quit sites, which helps facilitate referrals and outcomes report, and I've also requested brochures from the Department of Health and Human Services. So based on the data and the pre- and post-interventions, I feel like the tobacco treatment training can be effective, and we can save lives by intervening in this way and providing a day-long training. Thank you.